Hello students, this is second part of your pain PowerPoint, and the first slide tells you that for any pain treatment there are certain principles which a nurse should consider. It says use a multimodal approach, which means that you treat pain by applying different strategies or activities. You have to take help of different disciplines. You can take help of maybe a physical therapist. You have to consult maybe a pain physician, or you have to consult maybe a palliative nurse. You might have to consult an oncology nurse. You might have to consult oncology expert doctor. You might have to consult a pain expert doctor. I might have to consider a nurse who's only who is very good in controlling pain through different categories of pain medications. So also, the duty of a nurse is not only to give these medications or to utilize these pain treatment methods, but also to evaluate the effectiveness. Managing side effects is also the job of a nurse, and involving patient and family also is part of a nursing process. So let's go to the next slide. As now, pain can be treated by lots of medications, and all these medications have been divided into three categories: opioids, non opioids, co-analgesics, or adjuvant. Before I go further, I want you to know what is the meaning of analgesic. What is analgesia? Um, in simple terms, it's like, a medication is relieving your pain without loss of any consciousness. So let's go to the next slide. Let's talk about non opioids. The first thing they have talked about is analgesic ceiling. The ceiling effect is the concept that there is a maximum level of, uh, you know, pain control or analgesia that can be reached with a dose of medication, and beyond that dose, you cannot get any more analgesia or pain control. So, no matter how much ibuprofen or Tylenol you're taking, it will have no therapeutic effect after a certain point. So, that's called ceiling, like ceiling of maximum effect on the body of this analgesic medication. Without that, if you go above that, it will have no more actually real effect on the controlling the pain. So analgesic ceiling is increasing the dose up above upper limit produces no greater analgesia or pain control. Um, these non-opioids are not famous for producing tolerance or addiction. Many of these you can find at over the counter, and most of these over-counter analgesics, they do not have any serious problems related to drug interactions, side effects, or overdose as you'll see in opioid analgesics. Well, that's another thing. If somebody just goes and pops up all the Tylenol, you know in the mouth, that's another thing. But usually the over-the-counter non-opioid analgesics are not popular for causing any serious problems related to drug interactions, side effects, and overdose. Non opioids are effective for mild to moderate pain, and sometimes non opioids will be used in combination with opioids because they allow for effective pain relief, with so with lower opioid doses. So if the doctor thinks that I want to give a lower dose of morphine. I think this patient needs morphine, but how about I start with lower dose of morphine? So how about I gave him just 0.25 milligram of morphine tablet, and how about this? I pair this with maybe ibuprofen, Motrin or something like that to get the maximum effect of reducing the pain in patient's body. Now, I have said go to this link to understand the difference between tolerance and addiction. So I do want you to go to this link, which is here with http mnphysicalmedicine.com, and I want you to go to blog by a doctor. I want you to go and I want you to understand the difference between tolerance and addiction. So this is important. Understand the difference between tolerance and addiction. So this is important. Okay. Let's go to the non-opioids. Now, this slide tells you more about non-opioids. So, kind of, it's just telling you what what medication exactly, which we know come under this category. So, there are aspirin and other salicylates class of drugs. Then there is acetaminophen, and then there is NSAIDs. Now, aspirin is effective for mild pain, but aspirin also has a lot of side effects, including increased risk for GI bleeding, any problem with platelets functioning, and and because aspirin is like salicylates, so it uh, it might cause less GI disturbances as compared to the other uh, medications, but it has a lot of bleeding abnormalities problems. But aspirin has a bigger side effect as bleeding GI, risk for bleeding a lot. Acetaminophen. Now this time, usually we know it by Tylenol, and it has both analgesic and antipyretic effect. Analgesic means like it reduces the pain as well as it is also used for reducing the fever. And like aspirin, it does not have any, uh, you know, serious risk for any bleeding, etc. And it is usually very well tolerated by the body, and it is well metabolized by the liver. um, but as I said earlier, if Tylenol goes for, if it has a overdose, then it can affect our liver. NSAIDs, they have a very broad class of drugs. You know, a lot of drugs which come into NSAIDs. Now, I um, don't want you to go too much into of pathophysiology, that how the NSAIDs control the pain and what happens with the enzyme COX-1, COX-2. No, I don't want to do that. um, it's just that you just need to know that NSAIDs are non-opioids, and that's all. And then there are some serious side effects of NSAIDs, um, like very serious um, bleeding, or but it can only happen if it is very high doses. So for right now, I want you to remember that aspirin, acetaminophen, and NSAIDs, they are part of non-opioids. So they are not usually used for severe pain. Let's go to the next slide. This is opioids. Now, opioids are categorized according to their physiologic actions, that is, agonist and antagonist. Um, all of you have gone through pharmacology in a course, and I think you should be aware of the meaning agonist and antagonist. Agonist is like, in pharmacology, it means a drug which is acting on some receptors in our brain, and it is provoking those receptors to produce a response which the drug wants. And antagonists are those drugs which will which does not which do not want agonist to work. Okay, so they do opposite of agonist. Antagonist is like to stop the agonist, like so if a drug is uh, working on a certain receptor in the brain and is trying to produce the therapeutic response which is intended to, and then the antagonist drug will come. It will say set to the receptor, it will block the receptor so that the response will not be produced. So that's the difference between agonist and antagonist. So opioids, the drugs in these class, they bind to receptors in your brain, And these receptors, which special opioid, they are special opioid receptors in your brain, and they are known as mu, kappa, delta. I don't know who named these. Mu, kappa, delta. Mu, mu, kappa, kappa, and delta, delta. So these are the three opioid receptors in your brain. Now I won't be testing you on mu, kappa, delta. It's just that you need to know that opioids bind to receptors in your brain, and they stop. They're usually um, now um, now no where it says inhibition of transmission of nociceptive input. So opioids inhibition of transmission of nociceptive, like they try to stop the pain which you are experiencing through nociceptive way. Nociceptive pain is caused by damage to or any dysfunction of the nerves. So no, sorry, no, I'm saying the opposite. Nociceptive pain, you have it is when you have a cut, bruise in your body, and this is kind of a temporary sharp or throbbing pain, and then you uh, take these take these class of pain medication, and then it goes away. So opioids, they bind to receptors in the CNS, plus they are helpful in controlling the nociceptive pain. Plus, they also change the limbic activity in your life. So limbic activity is your emotions, when you cry, when you feel anger, when you feel happy. So all these emotional activity, also these opioids can make some change in that. And the descending inhibitory pathways, these opioids can activate some pain suppression mechanisms, which are like descending inhibitory pathways. So these are the just a explanation of how the opioids work in body. I have no intention of testing you on this, because I just want you to know from this slide is that opioids have some specific receptors in the brain on which the opioids bind to. There are opioids which are, next slide, there are opioids which are known as pure agonists, like these pure agonist opioids, they are like morphine like opioids, and they bind to mu receptors, mu receptors. um, Now, as I told you earlier, an agonist is any kind of substance or chemical that binds to a receptor and activates the receptor to produce a biological response. So, pure agonist opioids are morphine, oxycodone, and codeine. They are very potent, they're very effective, very potent. They have no analgesic ceiling like this. This means that you can keep on increasing to give more effect, pain relief effect to the body, and they have several routes for administration. Sometimes these morphines are combined with non-opioid analgesics for relief of moderate pain. Now, let's go to the next slide. This is mixed agonist antagonist. So there are some opioids which have properties of both agonist and antagonist, and these are nalbuphine, pentazocine, butorphanol, and they have less. These mixed agonist antagonists, they have less respiratory depression, more kind of uncomfortable or agitated effect, and they have an analgesic ceiling. So the mixed agonist antagonist opioids, they have analgesic ceiling, like after a certain point, if you use these, even if you increase the dose of these medications, still you won't get the higher effect which you might be hoping for. And they can also aggravate the withdrawal if these drugs are withdrawal, if the patient is going through withdrawal due to these drugs. um, in this trials, I'll be happy if you know that that nalbuphine, pentazocine, butorphanol, these are mixed agonist antagonist drugs, and they have an analgesic ceiling, less respiratory depression, and can precipitate withdrawal. Common side effects. Next slide. Common side effects of opioids. These are constipation, which is very common, nausea, vomiting, sedation, respiratory depression, and itching. Now, many side effects they go away. The exception is constipation. Constipation stays there for a long time and is the most common opioid side effect. Uh, that's why uh, uh, it's all it's always said that you should always encourage patient to have a bowel regimen, so that encourage them to go and do poo poo at routine time. um, and also you can encourage patient to have some roughage, dietary roughage, fluids and exercise, so that patient does not get enough peristalsis happen and patient is not getting too much of the side effects of constipation. Sometimes, if the patient is experiencing too much of constipation, then you must have seen on floors patient getting a stimulant laxative known as Senna, or they get the stool softener Colace. So, nausea, vomiting is a very common problem with opioids, and usually the nurses they on the floor they give them Reglan, Zofran, to minimize the opioid related nausea, vomiting. Um, sedation, sedation and respiratory depression. These are the two of the most common fears which are associated with opioids. Uh, Now, sedation usually is seen in people who are very new, like very naive to the opioids. So now, if you are in the hospital, you have patients who are receiving the opioid analgesics for pain relief. As I said earlier, you monitor them regularly, especially in the first few days after a surgery, if they were on these, if they were on opioids. The risk for sedation after surgery or after the operation period is very high within first 4 hours of leaving the post anesthesia care units. So both the sedation and respiratory depression are big concern. Itching is another common side effect of opioids and occurs most frequently when opioids are administered via, like through epidural or intrathecal routes. So sometimes, you can um, um, try to manage these itching by giving another low dose infusions of some mixed agonist antagonists such as nalbuphine. Okay, let's go to the next slide. Adjuvant therapy. Adjuvant therapy is when the doctors thought that we are giving these chronic pain patients chronic pain. It is usually in chronic pain, such as cancer pain, and we are giving these patients these pain medications, and then it's not being controlled. So what can we do now? So how about we give some other class of drugs, maybe like antidepressants, or anti seizures, or steroids, or maybe muscle relaxants, or other stuff which can depress these CNS to uh, which are depressing which have a possibility of depressing CNS along with what our pain drug is doing, and that will help patient more. So how about we do that too? So adjuvant therapy is um, that therapy which is used in combination or in conjunction with opioids and non-opioids. So patient can have an opioids pain medication or non-opioid pain medication, and still they can have, along with whatever they have in the opioids and non-opioids, they can still have these the another class of drugs to treat pain. The adjuvant therapy is generally developed for other purposes but also effective for pain. Let's go to the next slide. So adjuvant therapy, the steroids, antidepressants, anti-seizure drugs, and GABA receptor agonist. GABA, the very common medication in GABA receptor agonist is known as baclofen, which is kind of a muscle relaxant. All these drugs, I don't want to know what class of drugs they are. I don't want to know, that the antidepressant is tricyclic antidepressants or anti-seizure drugs and what. No, I just want you to know that apart from opioids or non-opioids class of drugs, there are class of drugs known coming under the category of steroids, such as dexamethasone, which is Decadron, or antidepressants, um, which can which can be used, maybe Elovil, amitriptyline, which is Elovil, maybe that can also be used. Anti-seizure drugs, which can be used to uh, control the pain, like gabapentin and lamictal, which you might have seen on the floor a lot. Gabapentin and lamictal being given to chronic pain patients, even though they are not they are not seizure, patients suffering from seizures. GABA receptor agonist, I told you, a very common drug on related to this you'll see on floor is baclofen. Okay, so these are the main class of drugs usually used in conjunction with, along with the other opioids or non-opioid drugs for the pain relief of a patient. Now, the other adjunct therapy is alpha-2 adrenergic agonist, local anesthetics, mixed mu agonist, opioid, NP5 reuptake inhibitors, and cannabinoids. Now, adjunct therapy, yeah, I'm not going to test you on this, so I'm not going to waste time explaining you this slide. A patient who has been treated with morphine by patient control analgesia is discharged from the hospital with instructions that all of the following medications may be used for pain. Which medication will the nurse instruct the patient to use first? So he was on a very high, he was on a kind of an IV pain medication through this pump, you know. But when he's getting discharged and he's going home, we want we don't want him to go back to aspirin. We want him to go to an oral pain medication which is higher in strength as compared to the other oral pain medications. So that's why the answer will be 4, which is oxycodone acetaminophen, which is known as Percocet. To make the transition from infusion PCA morphine to oral dosing, oral oxycodone should be given even before the morphine is discontinued. Because, and if you look at the equi-analgesic dosing chart, it says yes, if the, you can, like the PCA, patient receiving PCA IV pain medication, that pain medication can be easily substituted to the oral oxycodone acetaminophen, which is Percocet. Okay, so see the reasoning behind it, that now the patient's pain control was happening through a very high level of IV pain medication. And if you tell him to go back to Motrin and aspirin, he'll go crazy. He wants, again, the route has been changed. It has been changed to oral, but the strength will be higher among all the oral medications. Let's go to the next slide. Administration. A patient should be pre-medicated before painful procedures and activities that are expected to produce pain. Similarly, a patient with constant pain should receive analgesics around the clock rather than on as needed basis. And I think most of you have seen on floors around the clock medications being given to the patient. Now, sometimes nurses give around the clock pain medication, and within few hours, there is, or maybe an hour, the patient wants PRN too, but you have to separate these two so that there is not too much of respiratory distress in patient. Next is administration titration. Dose adjustment. Titration is dose adjustment based on assessment of analgesic effect versus side effects. So it's like how you manage pain will also depend on how you titrate the dose of the pain medication. And this is done by the doctor. or you can titrate an analgesic if there is a standing order by the doctor. For now, use the smallest dose to provide effective pain control with fewer side effects. In post-operative patients, the dose of analgesic generally decreases over time as the acute pain resolves. On the other hand, opioids for chronic severe cancer pain may be titrated upward many times over the course of therapy to maintain adequate pain control. So titration is not just making it up, titration is also making bringing the dose down. So after surgery, um, somebody is going home on a high strength pain medication, oral pain medication. And after a while, that patient doesn't need it because the surgery pain subsided. On the other hand, if somebody has fibromyalgia, multiple sclerosis, back pain, cancer pain, and they might not be happy with this dose of Percocet, which they have gone home. Maybe they need some higher dose than that to control the pain. Now, equi-analgesic dosing, I did talk about this in my first PowerPoint of pain too, so I will not spend much time on it. And it just permits the substitution of analgesic in the event that a particular drug is ineffective or causes intolerable side effects. It's just good to know. Administration routes. There are benefits of variable routes for giving pain medication to the patient. You have to achieve the therapeutic blood levels, avoid certain side effects, and provide analgesia when patients cannot swallow. So, if patients cannot swallow, you still have to give pain medication, usually through IV injection. Um, Let's go to the next slide. Administration routes. You all are familiar with it: oral, sublingual, and buccal. Uh, then there's something called intranasal. Now, intranasal administration allows delivery of medication to very highly vascular mucosa and avoids the first pass effect of the drug. Rectal route is often overlooked, but it is particularly useful when the patient cannot take an analgesic by mouth, such as those patients with severe nausea and vomiting. So they can be rectal. So before going for IV or something, we can try rectal too. Other administration, next slide, other administration routes are transdermal, parenteral, which is IM, subQ, and IV, intraspinal, which is highly potent given within the uh, spine, and then usually what they do is that they'll accomplish this by implantable pain pumps. So inside the body, in the abdomen, they might by surgically a doctor will place inside a small pain pump, and it will have a catheter attached to it, which will be going inside the spine, and it releases pains, periodically. It releases pains in low dose and um, to ease the pain of somebody who's suffering from a chronic pain condition. Patient control analgesia, I did explain to you about this in your first PowerPoint. Yes, so this slide talks about intraspinal delivery of pain medication again. And as I said, it just involves inserting a catheter in the subarachnoid space in the back or the epidural space, and then analgesics are injected by intermittent bolus doses or by continuous infusion. So the pump inside the body will be giving off the pain medication slow or on and off or continuous. And these drugs are highly potent. So if there is already a pain medication implanted inside the body through a pump, think about this if somebody is taking also pain medication with mouth. So we need to keep track of this so there is not too much of overdose happening. It's again the same repeat implantable pumps and patient control analgesia. Sometimes there are non-drug therapies: massage, exercise, acupuncture, heat or cold therapy, Acupuncture is Chinese medicine in which very thin needles are inserted in the body at designated points, and it is used for many different kinds of pain. Next, go to the next slide. TENS or PENS, transcutaneous electrical nerve stimulation, involves the delivery, and the next slide will show you the picture, and it just involves the delivery of an electric current through electrodes, and they're applied to the skin surface over the painful region. So just like you put electrodes for those telemonitors, so they are electrodes, and they are applied onto the skin, and then through uh, nerve stimulation, a pain control is done electronically, and usually physical therapist is involved in it. I have no intention of testing you on this. So this is the picture where it shows how the TENS treatment is being done by a physical therapist. So non-drug therapy. Non-drug therapy continues distraction, hypnosis, imagery, relaxation are another ways. And then the last question is the nurse's role in analgesic titration for a post-op patient is. So analgesic titration means that somebody had a surgery and now they are on pain medication, and they are on analgesic, like some pain relief medication, which is not letting patient lose consciousness, and now it should be titrated. So what are the nurse's role in doing that? So the first is monitoring the effects of continuous infusion of opioid analgesics, determining with the patient the doses of analgesic required for pain relief, teaching the patient to try to increase the time between doses of pain medication, and assisting the patient to plan the distribution of a specific total dose of analgesic over a 24-hour period. The answer is 2, because titration is dose adjustment based on assessment of the adequacy of analgesic effect versus the side effects produced. Now, titration is not limited to continuous infusion of opioid analgesics. Analgesic scheduling should focus on the prevention or control of pain rather than the provision of analgesics only after the patient's pain becomes severe. And pain management for a patient, assisting the patient to plan the distribution of a specific total dose of analgesic over a 24-hour period is not applicable, because this is describing the pain management for a patient with chronic pain, not post-operative pain. So the best answer is number 2. So that brings us to the end of this second pain PowerPoint presentation.